Hello, my name is Rebecca Sirbu. I'm with California Southern University, and this is for PSY 8724, Cognition, Emotion, and Motivation with Dr. Barbara Pierce. And today we're going to go over panic disorder, physiological processes, causes, and evidence-based treatment. So what is panic disorder? The DSM-5 defines panic disorder as recurrent and unexpected panic attacks that peak within minutes and include sudden intense fear or discomfort and at least four of the following symptoms. As you can see, some of those symptoms include palpitations, chills or feelings of overheating, feeling of losing control, fear of death or dying, chest pain or discomfort. So lots of different types of symptoms are involved in panic attacks. And these attacks need to be followed by 1 month or more of persistent worry about reoccurrence of the attack or significant maladaptive change in behavior to avoid activities that may trigger attacks. Some of the associated features with panic disorder are anxiety, extreme reactivity to mild physical symptoms, significant worry about ability to conduct aspects of daily living, substance use, whether legal or illegal, to self-medicate, and extreme behaviors in an effort to control the attacks. So for example, if attacks are started by perception of increased heart rate, an individual may avoid any type of exercise or activity that would increase their heart rate. So typically, panic attacks occur in adults. They're very unlikely in children, though they can emerge in adolescents. And there's a pretty low prevalence in older adults. They are more likely to occur in women than men, with about a 2-to-1 ratio. And as you can see, a lot of the risk factors include high stress environments for history, trauma history, adverse childhood experiences, and some medical conditions such as asthma, a history of smoking, or parental history of anxiety, depression, and bipolar disorder. So about 80% of individuals with panic disorder will have a comorbid mental health condition. Given that panic disorder is clustered under anxiety disorders, it should come as no surprise that there is significant comorbidity with other anxiety disorders, such as phobias, generalized anxiety disorder, and agoraphobia. In fact, approximately 64% of individuals that meet criteria for panic disorder also meet criteria for agoraphobia. And when the comorbidity is present between panic disorder and agoraphobia, it's usually associated with more severe and persistent form of panic disorder. Panic disorder is also associated with major depressive disorder, with about 35% of individuals meeting criteria for both. Though it's pretty unclear if this is due to shared personality traits, shared neurotransmitter pathways, similar environmental factors, or panic disorder causing major depressive disorder and vice versa, major depressive disorder causing panic disorder. Approximately 14% of individuals with panic disorder will also be diagnosed with bipolar disorder, though this does not appear to be due to a shared genetic trait and is unclear why this may occur. And again, approximately 22% of individuals with panic disorder will be diagnosed with post-traumatic stress disorder as well. However, this could be due to overlap in symptomology, or the symptoms of PTSD could be causing the panic disorder. And finally, about 25% of individuals with panic disorder will also have a co-occurring substance use disorder. However, like major depressive disorder, it's unclear if this is because the panic disorder causes the substance use and abuse, or if the substance abuse is instigating the panic disorder. So some of the physiological processes involved in panic disorder. So panic is associated with stress response in the brain. During a panic attack, the amygdala becomes hyperactive, stimulating the stress response. The amygdala sends signals to the para-aqueductal gray area, which then stimulates a fight, flight, or freeze response. The fight, flight, or freeze response is an instinctual response for survival that occurs in the presence of both conditioned and unconditioned fear stimuli. If the ventrolateral para-aqueductal gray area is activated, it results in the freeze response, dominated by the parasympathetic nervous system, and causes immobility with increased muscle tone and greater environmental perception to prepare for fight or flight responses. If the dorsolateral para-aqueductal gray area is activated, initiates the hypothalamus and the sympathetic nervous system, the sympatho-adrenomedullary system, and the hypothalamus pituitary adrenal axis, or HPA axis, which initiates a flight or flight response. When these systems are activated, the brain is stimulated to release neurotransmitters that prepare the body to fight or flee by increasing heart and breathing rate, dilating the pupils, increasing blood flow to muscles while simultaneously decreasing blood flow to the digestive system, and increasing sweating. However, in panic disorder, the fear stimulus that invokes this response is often innocuous. So why does this occur? It's because of cognitive processes in the frontal lobe that also contribute to the manifestation of panic disorder. As noted previously, one of the associated features of panic disorder is extreme reactivity to mild symptoms. Thus, a person may feel a mild symptom such as increased heart rate, and cognitive processes, including cognitive appraisal, attributed to a major medical episode or recognize it as a precursor symptom to a panic attack, and it becomes a self-fulfilling prophecy. It is a cognitive process itself sets off the stress response in the brain, sending the individual into a full-blown fight or flight response. So which neurotransmitters are involved in panic attacks? In panic disorder, hyperactivity of the noradrenergics can cause increased anxiety. Reduced gamma-aminobutyric acid, or GABA, and altered serotonin uptake is also present. GABA is a primary inhibitory neurotransmitter for the stress response, and along with serotonin, helps to suppress the stress response. In addition, heightened levels of glutamate and dysfunctional receptors for dopamine are also noted in panic disorder. Glutamate is a primary excitatory neurotransmitter, and along with dopamine, initiates the stress response. Once the stress response is initiated, the sympathetic nervous system releases norepinephrine, sympatho-adrenomedullary system releases norepinephrine and adrenaline, and the HPA axis releases corticotropin releasing hormone and vasopressin, which causes the pituitary gland to release adrenocorticotropin and the adrenal system to release cortisol. Hypercortisolemia is often present in panic disorder due to persistent stress response. So what causes panic disorder? So now that we know the areas of the brain and neurotransmitters are involved, we turn to why panic disorder occurs in some individuals and not others. There are several different theories regarding the origin of panic disorder. And as many psychological disorders, some theories may account for some cases, other theories account for other presentations. There is no definitive cause for panic disorder, though it does continue to be studied. One theory regarding the cause of anxiety disorders, including panic disorders, is neuroinflammation. With this theory, anxiety disorders like panic disorder are the result of chronic stress that causes a negative feedback disruption in the HPA axis, increased sympathetic nervous system activity, and decreased parasympathetic nervous activity. In other words, disruption of the HPA axis causes the sympathetic nervous system to go nonstop, which causes an increase in cytokines and pro-inflammatory conditions that act as neurotoxins on the brain and increases glutamate. Thus, neurotoxins and neuroinflammation alter the brain structures and neurotransmitter balances, resulting in panic disorder. Another study postulates panic disorder as a result of inhibited glutamate function, which causes overactivation of the amygdala and subsequent amygdala dysfunction that results in persistent conditioned fear. If the conditioned fear responses are not extinguished, even when there is no tangible threat, then individuals develop panic disorder. Other studies indicate that increases or decreases in brain oscillations or rhythmic brain waves that help different areas of the brain communicate with one another contribute to panic disorder. Increased gamma oscillation activity in the medial frontal cortex and paracentral lobular regions affect an individual's ability to integrate information across different brain regions, resulting in greater sensitivity to sensory input. The greater sensitivity then contributes to an increased amygdala reactivity and overactive stress response. Another study indicated that individuals with panic disorder demonstrated reduced theta-gamma coupling and theta power in the brain, resulted in disrupted communication and working memory deficits. This makes it difficult for individuals with panic disorder to disregard irrelevant information and affects their ability to engage in everyday tasks, leading to diminished quality of life and heightened anxiety. However, it is unclear if this is the cause of panic disorder or a result of panic disorder. Finally, Emerging gene studies have also offered underlying mechanisms for panic disorder. While panic disorder has an estimated 48% heritability, its genetic basis is fairly complex and differs between cases. However, recent advances using C. elegans studies has indicated loss of function mutations in the TMEM132D gene increases risk of panic disorder by inhibiting the wave regulatory complex that results in defects in neuronal morphonology and abnormal neuronal structure. So what are the treatments for panic disorder? Antidepressants such as selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors are the primary pharmacological intervention at this time. These both work by blocking different neurotransmitters and increasing the amount of serotonin or serotonin and norepinephrine available, thereby inhibiting the stress response. These medications are typically well tolerated and effective when taking it for at least 6 months, but preferably 12 months. However, they can take some time to go into effect. SSRIs can take 1 to 6 weeks to take effect, and SNRIs can take 6 to 8 weeks to become effective. Another class of drugs, benzodiazepines, work quickly and are considered for short-term use, but are not routinely used or were used for long-term due to risk of addiction, withdrawal symptoms, rebound anxiety, tolerance, and increased mortality. Cognitive behavior therapy can be used by itself or with the addition of pharmacological intervention. Cognitive behavior therapy works on the role the cognitive processes and cognitive appraisal play in maintaining panic disorder. It targets the cycle of self-fulfilling panic disorder by using cognitive restructuring to change maladaptive thoughts and target misinterpretations of bodily sensations. Cognitive behavior therapy also utilizes exposure therapy to eliminate avoidance of panic-inducing scenarios. They can also incorporate relaxation strategies and mindfulness to reduce overall stress and anxiety that may further exacerbate panic disorder. Cognitive behavior therapy and exposure therapy provided through virtual reality has also shown promising results of the treatment of panic disorder. Virtual reality and app-based modalities are often more cost and time-effective for patients, and patients often feel more comfortable with initial exposure-based therapy in a virtual reality world. Virtual reality world can also be more customized to the specific environment or scenario that commonly triggers panic attacks. Moreover, virtual reality-based interventions can help treat individuals that cannot reliably access mental health therapies. You also have to consider treating diverse populations. So one of the things you have to ensure is diagnostic accuracy. One of the largest differences in symptomology affected by culture you may experience is that typical descriptions of panic attacks and disorders may be different and often not categorized as unexpected. So when diagnosing panic disorder in individuals from other cultures, you must be careful to listen to descriptions of cultural syndromes to determine if what the individual is describing meets diagnostic criteria for panic disorder or is better explained by another psychological disorder. If the patient does have panic disorder, you should involve them in treatment planning of their intervention. So if they are adverse to taking medications, you should avoid medication pharmacological intervention and focus more on cognitive behavior therapy. You should also choose culturally sensitive evidence-based interventions. So for example, cognitive behavior therapy can be adapted to be more culturally sensitive. And instead of working on the Western interventions of direct communication and direct coping strategy, maybe you modify it to work on more indirect communication and indirect coping strategies to adjust for the cultural norms of your patient. And finally, you should incorporate culturally relevant practices or treatment. For example, many cultures tend to turn towards religious figures to assist with psychological distress, and that should be encouraged and incorporated into intervention. So thank you so much for joining me today to talk about panic disorder.